Okay, so let's talk about what neuro assessments you're going to need to do on a routine basis. Now, every facility and unit may vary, but typically you're going to do these neuro assessments with every head to toe assessment, which could be every 4 to 8 hours. And you may also do them Q2 hours or even Q1 more often, depending on what's going on with your patient. So, the first thing you'll assess is level of consciousness. You need to know how alert they are. You need to know how oriented they are, and you need to know their response to stimuli. Refer back to the level of consciousness lesson for details on that. Then we're going to assess pupils, we'll assess strength, and we'll assess the Glasgow Coma scale. So let's look how to address each one of those things. So along with level of consciousness, pupillary assessments are some of the most fundamental neuro assessments that we perform. They say the eyes are the window to the soul, but I say the eyes are the window to the brain. The acronym we use for knowing what to assess is PERLA. It stands for pupils equal, round, and reactive to light and accommodation. So the first thing that we look at is whether the two pupils are equal right to left. So here's a few examples of normal, unequal, dilated, and constricted pupils. So when we look at whether or not they're equal right to left, you can see here this one is much larger than this one. So the patient's right pupil is larger than the patient's left pupil. Now, sometimes patients have had cataracts or other surgeries that give them abnormally shaped pupils, so we need to determine whether or not they are perfectly round. Now, all the pupils that you see here are actually round, so that's good. Then the next thing we're going to do is shine a light in each eye to determine if they react and if they constrict briskly. And that would be expected. Now, you could also have a sluggish reaction, but ultimately we just want to see that it actually reacts. Then we're going to look at size. So here's a few examples here of sizes. We could be 1 millimeter, 2 millimeters, 4, 6, 8, etc. So this person right here who has normal pupils, I would say their pupils are about a 4 millimeters, and they're equal on both sides. Now, the last thing we check is accommodation, and I'll be honest, most people don't check this, but they still chart PERLA. What we do is we have the patient look at our nose, so they're looking directly at our nose. Then we're going to put our finger up and have them shift their focus from our nose to our finger. So when they're looking at something that's a little bit closer to them, their eyes, their pupils should constrict in order to focus on that closer object. That is called accommodation. So if all of these things are present, you would document pupils equal, round, and reactive to light and accommodation. You would say what size they are, 4 millimeters, and usually I'll write brisk. Now, if one pupil is blown, like in this image, they may have a stroke or a bleed on the brain or a lesion on that side of the brain, okay? So any pupils that are fixed and dilated like this is definite sign of a neurological problem. So the next thing we want to assess is strength. This is a really quick way to determine if there's any neuromuscular issues or if the patient may have had a stroke. We test things like grip strength by asking them to squeeze and release our hands. We can have them lift their arms up, lift their legs up off the bed against gravity and then against resistance. So then we can have them push and pull, and we're going to give them a score. We're going to score each extremity individually. So a 5 out of 5 is full strength. 4 out of 5 means if I put some resistance on them, they're going to be able to overcome it a little bit, but they're going to pull back some. 3 out of 5 means they can't overcome that resistance. As soon as I start pushing on their arm or their leg, it's going to fall back down. 2 means they can't overcome gravity. That means they can't even lift it off the bed. 1 is you might see a muscle flicker. You can tell they're trying, but really they're not even able to move it side to side. And then a 0 is there's no movement, not even a muscle flicker. Now remember that if they have one-sided weakness, then that could be indicative of a stroke. Make sure you check out the stroke lesson to learn more about that. Now, the Glasgow Coma scale, or GCS, was initially designed to be an initial assessment of mental status. For example, when we first encounter the patient or when they arrive in the emergency room. These days in clinical practice, it's actually used as a routine assessment. So what we're looking at is their best response in each of these 3 categories. Whether they open their eyes, how they respond verbally, and how they respond physically or their motor response. Now, eyes can score from a 1, where their eyes don't open at all, to a 4, where they open spontaneously without you having to stimulate them. Verbal scores also from a 1, which is no response whatsoever. That means no sounds at all. If your patient's intubated, trached, or aphasic, they receive a 1 even if they can write their answers. Now that progresses based on what sounds they make and how oriented they are, up to a score of 5. And then motor response gets a 1 for no response at all, a 2 and 3 if their movements are abnormal, which we'll look at in just a second. 4 if they withdraw, which means that they pull away from the pain. 5 if they localize, which means that they reach towards the pain. Now, usually we say they have to reach across midline to be able to give them credit for localizing. And a 6 if they obey commands. So overall, we have possibility of 4 plus 5 plus 6, which is 15. A person with a GCS score of 3 is in a coma, and 15 would be like you and me, normal, expected finding. Now, when we talk about these abnormal movements, I want you to know the difference between abnormal flexion and abnormal extension. When a patient doesn't follow commands, we'll give some sort of noxious or painful stimuli in order to see how they're going to respond. Now, if they reach towards it, that's localizing. If they pull away from it, that's withdrawing. But the next levels are abnormal flexion and abnormal extension. These two things are also known as posturing. Now, abnormal flexion is also known as decorticate posturing. Now, I remember this because it comes towards their core. Okay, decorticate towards their core. It's almost like they're trying to protect their vital organs. So this is a little bit of a better sign than the other type of posturing. So abnormal flexion, their arms come in towards their core, also called decorticate posturing. Now, decerebrate is actually away from their core, and this is what is known as abnormal extension. Now, again, decorticate is protective. They're leaning towards their vital organs. They're trying to protect their heart. With decerebrate, you're going to see their hands and their wrists extend out to the side. Their toes are going to point, and this is a worse sign. It's a poor sign of neurological function if they're doing this abnormal extension. Now, this would score a 3 on the GCS scale, and this would score a 2. And again, both of these are indicative of pretty significant neurological issues. So those are our basic neuro assessments that we'll do for every patient. We assess their level of consciousness by checking alertness and orientation and response to stimulus. Then we'll check their pupils, and the size, reaction to light. We want to see that they have a full perla. We're going to check their strength on all 4 extremities and give them a score out of 5. And then we're going to check our GCS, our Glasgow Coma scale, and give them a score from 3 to 15. Now, I will tell you, I remember I had a student once come to me to give me a report on her patients, and she told me all about her assessment and her conversations that she had with her patient. And then she said, "Oh no, I forgot to check a GCS." I was like, "Hang on, I promise that you know what their GCS score is, okay?" I said, "Did they have their eyes open when you went in the room?" And she said, "Yeah." I said, "Okay, were they oriented times 4? And she started to giggle because she was figuring this out. She said, "Yeah." And I said, "Did they follow commands, move and turn around when you asked them to?" And she laughed and she said, "Yeah, so I guess it's 15, huh?" So moral of the story is you can perform a lot of assessments concurrently. You can perform a lot of these things at the same time. You're gathering so much information just by looking at the patient when you walk in the room. So practice these assessments, find your rhythm, and you're going to be able to catch these neuro changes really quickly. So go out, be your absolute best selves today. And as always, happy nursing.